the residents are all aware. They are trainees, and I think it's important to know that we are getting more and more sophisticated about thinking about how we train residents. Dr. Jung works with the Department of Surgery. She studies residency training, residency competency, and I think this is really important in our current era as we really try and study quality over quantity and see if we can get people trained better and faster. So, Sarah, thank you very much for coming and giving us a talk today. Appreciate it.
Yeah, thank you. Thank you for having me. Can folks hear me okay? Sounds good. Right. Thank you. Well, thank you so much for the introduction. As I said, thank you for having me this morning. I always appreciate the chance to talk about some of the work that we're doing in the Department of Surgery, particularly with other surgical colleagues, to see, where there might be areas of overlap, shared interests, potential collaboration. So I'll talk through some of the things that we're doing and some of the background for it, but we don't need to wait till the end for questions. If people have thoughts or want to interject, please feel free. So I have no disclosures. I thought before I started, I'd tell you a little bit about myself, and sorry to anyone behind the column there who can't see me. But I, again, am a faculty member in the Department of Surgery, but I'm an educational psychologist. So my background is actually in learning sciences, which is the study of how people learn and how we create learning environments. I did my graduate work here at UW-Madison and then started working in the Department of Surgery 10 years ago now, which I'm like, how did that happen? But in 2014. And I've done work in a variety of learning environments, so K through 12, more informal learning environments, and then now spending the last 10 years primarily focused on thinking about and better understanding the surgical learning environment. So what do we want to accomplish today? And I know that everyone needs to get to the OR at 8:15, so we will be expedient with our time. But I do want to talk a little bit about this idea of learning environments, right? And some of the things that we may consider as we're designing and learning environments. We'll talk a little bit about competency-based assessment, actually a fair amount about that. And I think, thinking about what does that really mean and how is medical education in general sort of moving in that direction? And how does it help us to accomplish some of the goals that we really want to when we're thinking about how we train medical practitioners, right? Particularly surgeons. And then I want to talk a little bit about some ways that we've operationalized this. So thinking about, how do we use then data that we might collect to think about things like individual development plans, right? To really best support our trainees. So there's a really great book. It's older now. There's actually another version that has come out, which talks about some different things, but Branford, Brown, and Cocking published a book called How People Learn, essentially. And they spend a fair amount of time delving into how we think about the design of learning environments. So often we tend to focus on the knowledge-centered aspect, right? What is it that we want people to know? But the argument here is really that, right, we need to also be focusing on how are we assessing that, right? How are we making sure that we serve our individual learners, knowing that, we have different things that we're bringing to the learning situation, different experiences, backgrounds, et cetera. And then how do all three of these interact in the community of practice that we have, right? So when I think about learning and learning environments, this is really the perspective that I'm coming from. So if we start with knowledge-centered environments, right, which is what we may think about initially, right? We think about things like, what are the skills I need to have? What's the knowledge, right? How do I apply those in terms of clinical reasoning, right? And M&M is a great example of thinking about, what are decisions that were made? What are decisions that we may make differently next time? Or did I make all the right decisions and, we still didn't have an optimal outcome? right? We also think about assessing competencies and milestones. We all have them, right? I pulled some of the ones from neurosurgery, right? So we have our, do I have a light? Oh, I do, right? So we have, you know, the competencies here, right? Our patient care competency, for example, and then our different levels, right? Where we may be expected to perform at different times throughout our development. But even with some of these, it can be a little tricky to think about, well, you know, if I fall, I don't know, not doing a very good job with my pointer, but if I fall in between a level 3 and a level 4, right, what does that really mean for me as an individual trainee, right? What do I have to do to kind of move up with this? So these are some of the things that we spend a lot of time thinking about. So knowledge-centered obviously relates to this idea of being assessment-centered, right? You can't really think about what you want someone to know or learn without also thinking about, well, how do I know if they've done that? So a few things to consider with regard to this is, why do we assess in the first place, right? Other than, you know, we're required to by some of the governing bodies, right? We need to be able to say, you know, our trainees are progressing, but essentially we assess to inform decisions. We assess to inform decisions about our trainees and about our programs, right? So we can kind of think of 3 broad purposes for assessment. We think, or I think a lot about this first one here, formative assessment, right? We assess to inform learning. We want to be able to give someone feedback as to how they're doing and where we would like them to go. We also need to have summative assessment, right? We all have our clinical competency committee meetings, right? Our things that we need to report to the ACGME, right? To be able to say, okay, we feel you know, that this is where this person is at this point in time. And then finally, we assess to evaluate our programs, right? If we find, for example, that our trainees are not, you know, hitting certain milestones that we would expect, and this is a pattern, right? Rather than being an individual reflection of the trainees, is probably more a reflection of our program, right? And so we can use that data to think about, what is it that we would like to be doing better ourselves as educators. So the other thing I always like to talk a little bit about with folks is the difference between assessment and evaluation, because often we hear these terms used interchangeably, and they are they're interrelated, but they're different things, right? Assessment is the information that we're collecting where we try to estimate something, right? Might be performance, skill, you know, some of the things that are less tangible, right? Like professionalism. Evaluation is how we use that information to make some sort of judgment, right? To make some sort of decision. Again, probably the most concrete for most of us here is, you know, is this person progressing as we would expect them to? Or for individual trainees, right? Do I feel like I'm progressing the way that I need to in my training program? So a few things to reflect on for all of you. What assessments do you currently use? And how do you feel like you currently use them primarily? Are they formative, mostly summative, to inform your program? What are some thoughts from the group? I know you didn't know it was going to be interactive, did you? Surprise.
I hope it's all of the above.
All of the above?
I hope so. But there is always an assessment, you know, that's constantly receiving that score as well. The evaluation of programs seems to be overly valued as opposed to assisted. I think that's a big, you know, movement in the last decade that is unfortunate.
Yeah, so a trend maybe more toward, and I think too, your point is really important, right? Because it's like, well, what kind of data are we getting? And is it the best data to actually do what we want, right?
I'll take it away from the personal thing about us and our residents and talk about med students. if the assessment of the med students is really a way to evaluate the needs, it's not really effective use of their tuition.
Yeah, so I think, as we're thinking about these things, right, and, hoping that we're able to do all of them, right, also thinking about not only are we doing these things, but what type of data do we collect? And do we think this is the best data to actually make the types of decisions that we want to make? All right, so where we've gone with this, and I will say in my work in the Department of Surgery, I primarily do work with our general surgery folks, vascular surgery, and then to some extent with plastic and reconstructive surgery and our otolaryngology colleagues. But we've started primarily in general surgery and now in vascular surgery with really a shift to competency-based assessments and a competency-based framework, which is really centered around the more frequent use of workplace-based assessments. So just to put us all on the same page with what I mean when I'm talking about workplace-based assessments, just highlighting this definition here, right? Different tools and processes that we might use to collect the data that we need to essentially make that evaluation, right? Make some sort of judgment of competence. And these data can be used in a summative, but hopefully a more formative way throughout training. So Prentice in 2020, and I have all the references at the end of my presentation if anyone wants to delve more into these things, but they did a really nice review of workplace-based assessments and what makes some of these, what makes this framework effective. And they actually have 12 things. I pulled out kind of the most high yield and related to this talk, but one, trainees should receive high quality narrative feedback. So narrative feedback about how they're performing in the workplace. And we'll talk about, again, different ways that we've done that. Using scales that are optimally meaningful to stakeholders, right? And so again, going back to Dr. Dempsey's point, right? Thinking about, well, what is the information that we're getting and how is it actually meaningful to our day-to-day practice? We need to obviously be trained on how do we use workplace-based assessments in ways that are effective, and then they need to be conducted by multiple assessors in a variety of contexts. So for us, this has really encompassed the idea of entrustable professional activities. I actually wish they would have called them everyday practice activities, but obviously I did not win that. But essentially that's what they are, right? So when I talk about EPAs, what I'm talking about is basically the things that you all do every day in taking care of patients. And this idea is, how do we better assess that, right? Assess the things that are meaningful in our day-to-day practice, right? And then on the back end, sort of think about, well, then how do those map back to our competencies and our milestones, right? Because one of the challenges that we often encounter with competencies and milestones, for example, is that, outside of the context, they're a little bit hard to use to really think about, well, how do I improve? And the other nice thing about EPAs that we found is that for many of our faculty, right, who aren't sitting on our clinical competency committees, for example, that's really the area that they're able to focus on, right? They're able to focus on, how do I give our trainees meaningful feedback on the things that they're doing with me every day in the perioperative care setting. So how do we actually assess EPAs? They're assessed on a participation scale. So how much is a trainee able to do, right? Is it limited all the way through, wow, I feel like this person is, ready to go out into practice? An important point is, there may be different levels with a similar case or procedure. depending on, the difficulty of the case, the phase, I will say, it's not uncommon, and I would argue developmentally appropriate for training, that many of our trainees become practice ready on pre and post-operative care before they're practice ready on intraoperative care, for example. So this is what one of the interruptible professional activities for a patient with an inguinal hernia looks like, so for general surgery. And as you can see here, it describes like the level, the framework, and then some of the behaviors that we would expect to see of these different levels in both non-operative and intraoperative phases. All right, so this is not a new idea, right? This is some work from a colleague of mine in Canada, and this particular article is from 10 years ago now, right? And so there's folks who have been working on this for a while. Canada, for example, has their competency by design work that they've been doing, where all of their training programs are switching to a competency-based framework. I think by next year, I want to say it was 2025 was their goal, right? And so in this article, they really point out, well, what is the difference, right, between what we might consider more of a traditional training paradigm and a competency-based curriculum? And essentially, the thing I like to point out here with regard to feedback is that it, instead of only emphasizing sort of summative feedback, right, things like end of rotation evaluations or clinical competency committee, summaries, it really emphasizes this frequent formative assessment as well as summative assessment. So these are the general surgery residency EPAs. I kind of like how they put them in a nice little body diagram. Helps people like me who are non-clinical. I'm just kidding. But there's currently 18. The ones that you see a little bit darker are the 5 that we've actually been piloting since 2018. And then this year, actually in July of 2023, they rolled out all 18. And this intern class is the first class that will actually have to submit their suite of EPAs in order to be able to sit for their general surgery boards. Vascular surgery has also rolled this out. So again, they're starting, I think, with their July 2024 interns, and we're currently piloting these as well. And then, again, the medical student EPAs have existed for a while, actually. They were kind of the first ones, some of the first ones to come out. I know there's work going on at the medical school here about how we can better utilize these. And then also there are quite a few fellowships in surgery that are now working on EPAs for their program. So my point in showing these is that it's really meant to be a way to think about the progression of competency, right? It's not just like, oh, you can do this. Okay, great. Now, great, you're good. It's really trying to emphasize this idea that, everyone's lifelong learners. You're learning quite a bit during your initial training, but, these things carry on into practice as well. All right, so I'm gonna pause here and just see if it's just kind of a summary of what I was just saying. Does anyone have questions, comments, concerns about this? Yeah.
I guess one thing that I'll struggle with is not just the technical part of surgery, but also the judgment part of surgery. Maybe you'll get into this, but how do you capture that? Assess that.
Yeah, like the critical thinking, the clinical thinking, the decision making. Yeah. And I will say, and I don't know if I have a slide that gets into that specifically. So I'll just comment on it now, I think that's one thing that as we've been engaging with collecting these workplace-based assessments, and certainly that's something that comes up in the descriptions, but I think it's a challenge. But we kind of see that comes out in the data, right? People often comment upon, not only technical skill, but also, decisions that were made both preoperatively, but also intraoperatively, right? And you do start to see kind of a pattern. And for some of our residents who maybe have needed some extra support in that area, we have seen that kind of play out in the EPA data, right? People will comment upon that. So I think, like you said, it's one of those things that can be tricky to nail down, but also people recognize that and often do comment upon that. And the nice thing about having these more frequent assessments is that, you can start to see patterns related to that, right? Which has been one thing that has really helped us, rather than sitting in our CCC committee and being like, okay, we don't really have very good end of rotation, evaluations for this person. So has anyone worked with them and what do you think, right? Now we actually have some data on those things where people outside of the committee have commented on things like skill, but also things like decision making.
And just, are you familiar with the neurosurgical milestones?
Mm-hmm.
So, am I correct that would be a part of the EPA program, not the complete replacement, but the part that has maybe some objective criterion here?
Yeah.
EPA then builds it on.
Yeah, exactly. And so the EPA is actually mapped to the milestones, and for the neurosurgery ones, they are not surprisingly in many ways more specific than many of the general surgery ones, but I think still are more. They would map onto the EPAs, and I won't have time to get into the dashboard and everything that we kind of use on the back end. I'll mention it, but we've actually created a mapping. And when I say we, I mean the work groups who did all of this EPA development. But when we get a report, we can actually see, based on how someone performed on their EPAs, what level may be recommended in terms of where they would fall in the milestones. And then the CCC can use that to help make their determination. Yeah. Okay. I had to throw in a little bit of theory here because I'm an educational psychologist, but I don't probably need to talk to you all about models of cognition, but sometimes people are like, well, why should I do this, right? I already give people feedback in the moment, which is great. And I'm not saying to stop doing that. But I think sometimes we fail to recognize just how cognitively taxed our learners' working memory can be, particularly in things that we have developed expertise in ourselves. So I always like to talk a little bit about how this relates to this idea of cognitive load theory, right? When we're doing anything, there's different types of cognitive load. Some of it is just intrinsic to whatever it is we're doing or whatever it is we're learning. Some of it is important to the actual learning process. But then there's also extraneous cognitive load, right? Are we getting paged? Are there distracting noises, et cetera? And so when we think about, particularly in the OR or other stressful settings, right? Things that might be taxing the cognitive load of our learners, it may be difficult to really take in of the feedback that's being given in the moment, right? And so, one thing that we've heard from the resident side is that, I really love being able to go back and look at the feedback from my faculty that maybe I would have received in the moment, or maybe I would have received intraoperatively and still do, but I'm not able to fully process it at that time. So it's nice to be able to go back and see that. So we actually use an app that we developed in-house to do this work. It's called the Surgical Entrustable Professional Activities, SEPA app. And essentially, It can be initiated by either a faculty member or an assessor, or by a trainee. And after you do something that you have worked on with an attending, you can go in and request an assessment, which requires our trainees to self-reflect on how they think they performed, and that will then ping our attendings to go in and assess them. Or the attending can self-initiate, and then it will ping the resident or fellow to go in and self-assess. And so this is what it looks like. The thing I like about our app is that it actually requires that you give some feedback, right? You can dictate it, you can type it, but you can't submit your assessment until you've given a little bit of feedback as to why you chose that level and how, what the performance looked like. And we also have a generic one, right? Because the EPAs don't encompass everything. So basically for any interaction that someone may have, they can go in, request an assessment, and get some feedback. And then this is a little bit of what our dashboard. So there's a both a mobile and a web-based version. And on the web-based version, there's a dashboard available. You can also see it on the app, but it's a little bit more smushed. But you can go in and look across time. How has performance changed? You can see differences in self-reflection versus assessor ratings, and it collates all of the feedback for someone. And we're looking at different ways to continue to do that and do that better using things like generative AI, natural language processing, etc. So if anyone has interest in talking about SEPA, I'm happy to, because like I said, we developed it here.
I'm a little disturbed by distrust of AI, as I think it's appropriate, but you know, it's going to come.
Yeah.
I know that some other chairs are like writing promotion letters by letting the machine do it, which falls me. Little concerned that these are going to all work a lot after a while. If those have some way to make them impactful. How do we do that in this world where everybody's going to be chat bot?
Oh, so I mean, it's interesting. I think, you know, it remains to be seen how we use AI well. I just came back from the Association for Surgical Education conference, and that was definitely like probably at least a quarter of the presentations and panels were on AI and using it for different things like looking at, you know, residency applications, etc. I agree. I mean, I think we have to be careful, and I think we have to acknowledge the limitations of it. I think for something like this, right, I would never suggest that, like, you know, someone use, you know, AI to write their feedback or anything like that. Ideally, it would be tailored to the learner. And then when we think about using AI to summarize, I don't know if that's going to be the best thing, honestly. And so that's why I think, you know, some of the people that are using it, I think it's good because we need to figure out how we best do it. But I do think sometimes we need to temper the excitement a little bit, right? Because we need to see, does this actually produce the results that we want, right? Does it help distinguish and really pull out the feedback for the learners that, you know, is individualized, or does it all end up looking the same? Because I agree, if it ends up spitting out essentially the same thing for every trainee, that's not useful. And
how much is it useful to tell the trainee that they're really good at appendix, but not that good at gallbladder? You know, it's kind of like worried that our assessment's going to be that, you know, you're really good on C3-4, but 5-6, you know, not so good. You know, they have different skills. There are things that are obvious, but it's this granularity for you.
Yeah, I mean, I think so, you know, but admittedly, as someone who's not a surgeon and doesn't like train people on the skills to be surgeons, right? And so I think that's why it's nice to have conversations with folks like you, because yeah, I would be interested, you know, you tell me, like, is there a level of granularity in neurosurgical training for which this would be helpful? Like, just, you know, holistically, I think about, well, yeah, it would probably be good, right? Because if someone's doing well here and not doing well here, there has to be something going on. And what is that?
The difference in general surgery, in my opinion, should be with the junior trainee, that the vascular skills are way behind the general skills, and maybe that's telling some about career choices or the areas you must focus on either way.
Yeah.
And there are such divisions in neurosurgery, but appendix versus gallbladder is unlikely to be a real difference.
Yeah.
So I'd be interested in hearing, we've done something like this for 10 years now. And what I found interesting is really determining what it means, how many evaluations you get that person's competent is, and in what areas did it have competence. So it's strictly the technical skills, or is it judgment plus the technical skills. So I think I'd love to hear your kind of what you've learned about that. Like, how do you develop the thresholds? Are those subjective, or are those still trying to determine kind of a objective way?
Yeah. So I can say what I know about, I'd be curious about what you've learned too, because I think that's something, you know, and that's something that people want as this has rolled out. And obviously this isn't a real training, just want people to know it's de-identified. There are folks who have been working on that, you know, who have more of a background in like psychometrics and figuring out, you know, how many assessments do we need from how many assessors. And not surprisingly, it varies depending on, you know, what is the case complexity, right? I mean, some studies have found like you need like 40 some from, I forget how many assessors, you know, which isn't unreasonable, but some people were like, oh my gosh, how are we ever going to get that? And then others have found different numbers. I think like part of the issue with this is that, you know, you want to know, like, how many do I need to at least say I can make sort of a reliable and valid statement about performance. But again, this should never be like, okay, now we know this, you know, for sure, right? And so that's the thing I try to emphasize to people as well. Like, this is just one of the assessment data points, and I'm using it as kind of a holistic, but like EPAs and workplace-based assessments are just one of the thing in the suite of assessments that goes into how do I make this decision. But yeah, I'm curious to, like, what have you found? Have you been able to nail down? Because people ask me all the time, they're like, how many do I need? And I'm like, I don't know, and the ABS is not going to tell you how many you need. So
right. So all this work came along with the milestones being developed. So all kind of conflated a little bit, but the reality is I don't think anybody knows.
yeah,
And what's been, I think, important things to try and learn about, but also a struggle, is that the more you dig in any other skills-based or say like technically advanced, cognitively advanced kinds of professions, it's hard to find these.
yeah,
And probably the only place that might have some of those data would be like NASA. Aeronautics probably has data like this, but like surprisingly, surgery and medicine generally doesn't. It's pretty wild to see, and I think part of that may come from the fact that it's isolated subspecialties, the various sides of the various workflows that don't necessarily have time to put together these projects.
And there's a lot more complexity and divergence of patients and conditions than there are applying. Yeah.
Oh, yeah.
Mhm.
Never tell her.
But
Pilot that, but I.
yeah.
Might have been an exciting trip, but yeah.
That would come by for brain. But this
I'm
is,
pretty sure the weather.
this is our living laboratory. It needs to be.
Yeah.
Because we want to improve. And that's the beauty of what's going on here. It's that, and it'll change. Something will be better 10 years from now, but this is where we are now. And we can learn from it.
Yeah, and honestly, from my perspective, like I find the feedback and the things that folks are able to sort of get and take away and reflect on. And in talking with our residents and fellows, like probably not surprisingly, because no one ever feels like they get enough feedback. Like that's the part that they like too, and that's the part of this that I like, right? Like I think it's great to be able to see progression and look at numbers and things, but really, to me, the value is in the fact that we are doing a much better job now of capturing frequent, in the moment or almost in the moment feedback for our trainees. Yeah.
So then the other part that we struggle with is some attendings are very, very hands-on,
Mhm.
especially in neurosurgery. Some are going to allow some freedom. But typically the ones that are hands-on are the ones that are going to complete this. The ones that are hands-off are the ones that are not going to. So we've got this other issue. We tried to do like a 360 so that once residents could evaluate the faculty's performance in the operation, how much help they can
Yeah.
see where they think they're at. They're often be the resident thought they needed to do more, and many thought they should do less. So in the middle to the active. So I think that's another hard part. It goes back to that subjectivity of how you're on a particular rotation, and attending like very hands-on and very, very much perfectionist. Just kind of not make it as far as if you are getting evaluated by somebody else. Okay, pretty good.
Yeah. I mean, I will say, and I also recognize we only have like 4 minutes left, and so, but I think this is a good place to kind of round out the discussion. I will say that, one, kind of to your comment about, people who would complete it and people who wouldn't. We have definitely had some surprises in terms of like, oh, so-and-so is never going to do this. This is just not their thing. And like, there have been people for whom this has resonated that I would not have anticipated. So I just want to put that out there that, I think some people, rightfully so, get really jaded with some of the assessment processes that we currently have in place and have been able to connect with this better. I mean, yeah, there is the issue of like some people just being more hands-on versus others. And obviously there's various things that come into that, experience, comfort, etc. One thing that we're still trying to figure out, right? A goal that we have is that the residents would actually be able to bring their EPA summary to an attending, particularly when they haven't had experience working with, and be able to say, look, I'm here's a summary of my feedback. Here's areas where I have strength. Here are some things I'm trying to work on. I'm at about a indirect supervision level, right? Can I work on, this thing, right? Like trying to use that as sort of a springboard for conversations about what they may do. We haven't figured out the best way to do that yet, or how to get people to really do that on a regular basis. So we're working on that. And then I'll just mention with our individualized learning plans that we started implementing for all of our trainees, we use this again as one component, right, of Do I have EPA assessments? What do I have them on? Kind of what is my general feedback in areas where I have strength, areas for growth, and then they talk about those things with their assigned mentor as part of their ILPs. Yeah.
You know, I think the dashboard is excellent because I think seen a lot of utilization of like data layouts and things can actually push people psychologically to understand what's going on as opposed to just having all the data kind of in a spreadsheet.
Mhm.
And so I think that's very helpful. Dr. Dept is going to cover his ears now, but like gamifying residency.
We've,
Uh-oh.
we've been trying to get it right for 40 years. Really good.
Yeah.
And it has to feel a bit different. We talked about the differences people at these fields and how they learn, how they teach. But it's very valuable. Not finished yet, but it's an iterative process.
Yeah, I mean, and I'd love to talk more with you about, what you're doing and what you've done and your pain points, because I'm assuming they're similar. I mean, like you said, Dr. MC, it's a work in progress, and we're getting better, but there's more to do. So
The most important thing is it's really.
yeah, well, thank you for having me. You have my presentation. Feel free to share it, and I'm happy to chat with anyone who wants to talk further about this. So, thank you.